Welcome to this course on OCT for all. When I say comprehensive ophthalmologist, I mean all of us. Whatever you may be doing, OCT is an instrument for you. It's an instrument which is versatile enough that not only is this the backbone of diagnosis for the retina surgeon, today an anterior segment surgeon can need it as much as we do, and not only the anterior segment surgeon, but even the glaucoma specialist needs it to do a good job of his management of glaucoma. So let's start off immediately. We first have over here Dr. Hemlata Gupta. She's a senior consultant at Center for Sight in Delhi, and she will be talking to us about anterior segment OCT. What all information can it give?
Can somebody please put the presentation on?
Excuse me, or AV.
A very good afternoon to all of you, and thank you, Dr. Dinesh sir, for giving me this platform to share my experience with anterior segment OCT use. So I'll be talking mainly about the clinical applications of anterior segment OCT in cornea and refractive surgery. So we use the AIOS-OCT to assess the corneal thickness and opacity, to evaluate the pre-surgical and post-surgical anterior segment anatomy, for guided laser-assisted cataract surgery, to image intracorneal ring segments, and to see the position and vault size of the phakic IOLs. And there are many more applications. I'll be showing few interesting cases also. So with AIOS-OCT, we can visualize almost all the layers of the cornea, starting from tear film, epithelium, Bowman's membrane. We can see all the epithelial layer irregularities, stroma, Descemet membrane, and endothelium. So we can diagnose and stage keratoconus based upon certain criteria in the central pachymetry map. This is how keratoconus looks like on the AIOS-OCT. So we can see the area of maximum thinning and also the location of the cone. And also we have the option of seeing the progression maps. Epithelial mapping is a newer concept which is based upon the observation that epithelium compensates for the underlying stromal surface irregularities. And it is seen as the inferior thinning corresponding to the area of thinnest cornea. And we use it to screen the cases of keratoconus, PMCD, as well as early detection of corneal ectasia. And in our routine practice, we use it for all the cases who are planned for trans-PRK to measure the epithelial thickness. Now, even before the epithelium is involved, we can see the disintegration of Bowman's membrane, which is seen as relative inferior thinning on the spectral domain OCT. Now, this is a case of acute hydrops. You can see very clearly that there is a disintegration of the Descemet's membrane with rolled over margins and the central stromal scarring. And this is how a demarcation line is visible, which is a direct clinical sign of corneal collagen cross-linking, and usually it appears after a month of the C3R procedure, and it tells us the efficacy of the procedure. We can also visualize intracorneal ring segments very beautifully. We can see the position and depth of the intacs, and sometimes the underlying stromal melting, if it is there few years after intacs, is very clearly visible on the AIOS-OCT. Now, another indication of the AIOS-OCT is in PTK planning. So whenever we see that there is a corneal scar, to manage that case, we need to know the depth of the scar, position of the scar. For example, this is a case, he was a 32-year-old male patient who had undergone LASIK surgery somewhere else, and the patient had paracentral scar. There was a lot of glare, and the refraction was -2, spherical with -1 cylinder, and the patient wanted repeat surgery, but the previous records were not available. We did AIOS-OCT to see the depth of the scar, and you can see that the scar is involving almost the whole thickness of the flap. But if you see very clearly, then the residual stroma is good enough, so we decided to just peel off the scar, and this is 1 month post-op. The patient had sufficient corneal thickness even after surgery. With RGP lenses, till date, patient is doing fine. Now, when post-refractive surgery, even the whole extent of the flap is very clearly visible on high-resolution OCT, even after years of surgery. And this feature is very useful when we plan LASIK enhancements. For example, in this patient, the patient came to us 10 years after the primary LASIK surgery with a refractive error of minus 1.75 diaspherical, and patient wanted resurgery. Now, to plan the resurgery, we need to know that how much residual stromal bed thickness is there, whether that allows us to treat this power or not. The residual stromal bed in this case was just 265, so it's not safe to relift the flap, so we proceeded with the surface ablation. And this is how epithelial ingrowth, when we see on the slit lamp, sometimes it's very difficult to decide whether to proceed with the removal of the epithelial ingrowth or just observe the patient. But if you do AIOS2025, like for example in this patient, the extent of the epithelial ingrowth is much more than we saw on the slit lamp photograph, and there is overlying melting of the flap. So that indicates that the epithelium ingrowth needs to be removed. This is another case where in the bottom image you can see that there are a lot of epithelial nests. We remove the epithelial ingrowth by lifting the flap, and 1 month post-op patient vision was 6/6, and you can see in the image that there are no residual epithelial nests left. Also, it's very helpful for the corneal surgeons to monitor the health of the defects. This is a very nicely attached defect graft with clear cornea on day 1. While in this patient, even after a week, the corneal edema was not resolving. We did AIOS2025, and there was complete detachment of the graft. Rebubbling was done, and within a day, the cornea got cleared, and there's nice attachment of the graft in the upper image. Now, around 14% of the Descemet membrane detachments are not picked up on routine examination because of dense corneal edema on day 1. So nowadays, we have started managing these kind of DM detachments on microscopic integrated AIOS2025. Can you play the video, please? So in this video, you can see this is intraoperative OCT. So you can clearly see that there is a linear Descemet membrane detachment. So here I am making side port, and we inject non-expansile SF6, and this is guided. So you know that you are going into the right plane, and you can see that as you inject SF, there is immediate reattachment of the DM membrane. So you can visualize on table only, and that prevents the patient from you need not take the patient again and again in the OT, and there itself you know that you're in the right plane and the DM has reattached. This is 1 week post-op with clear cornea. Can you please play the video once again? So this is again one interesting case of a 28-year-old female with acute eye drops. There was a lot of corneal edema in the center with stromal scarring. We are here again doing desmetopexy, which is anterior segment OCT guided. And when you inject the gas, immediately the Descemet reattaches. All the features that are there in the acute eye drops are visible on the AIOS2025. So this is 1 week post-op with almost clear cornea, though there was still stromal scarring was persisting. Now all the femtosecond lasers, they also have real-time OCT integrated in that, and that feature is very useful when we deal with the posterior polar cataracts. Video please. So this was a case the patient has posterior polar cataract with pre-existing capsular rupture. It was visible on the slit lamp examination only. So we took up the patient for femto laser. You can see that in the femto image itself, it's very clearly visible that there is disruption of the posterior capsule. So what we can do in these cases is when we can just increase the offset, means we can decrease the area of lens fragmentation. We are decreasing here the offset to 1000 microns, and that leaves the endonuclear cushion behind. Now that cushion is going to act as a shock absorber. It will just take the turbulence and prevent the nucleus drop. So here we take up the patient for surgery, and since the cataract was soft, it was very easy to, you can see the posterior capsule rupture that is there on AIOS2025. Once the nucleus is out, this is the endonuclear cushion, 1000 microns that is there, that prevents the further damage to posterior capsule. We remove the cortical matter, and you can see that has increased the safety of the surgery. The posterior capsule rupture, despite posterior capsule rupture, there's no vitreous herniation. The vitreous is there, but with the intact hyaloid. So there was no need of anterior vitrectomy. We implanted 3-piece lens inside the capsular, inside the sulcus. Another application is to measure the vault size of the ICL. The vault size of the ICL is the distance between posterior surface of the ICL and anterior surface of the crystalline lens. The ideal vault size is somewhere around 250 to 750 microns. But if you see a vault like this, a very low vault, that predisposes the patient to cataract. And if the vault size is very high, then the patient is predisposed to pupillary block glaucoma and pigment dispersion. This was a case where the surgeon realized on day 1 that the ICL was upside down. So we have to take out the, this is very clearly visible on AIOS2025-IC421, and we had to take the patient to the OT, expand the IOL and re-implant the same ICL. So to summarize, AIOS2025 is essential tool not only in diagnosing but managing the anterior segment cases. It helps detect findings, structures that may be hidden in the routine investigations. And microscopic mounted AIOS2025 is an additional tool to maximize the surgical outcome in certain cases as shown in the presentation. Thank you so much.
Thank you, Dr. Hemlata. Any questions from the audience for Dr. Hemlata or from any of the panelists? So Hemlata, in your clinical practice, is there any particular situation where as a routine you plan that you have to do an anterior segment OCT before you go ahead?
So we do it in all cases of trans-PRA, PRK, because epithelial thickness is measured, and the same thickness we feed in the LASIK machine. So that is the precise removal of the epithelium. And then we do it in all cases of redo surgeries of LASIK, because we need to know the depth of the flap. And then we do it in Descemet membrane detachments in all cases.
And are we using the intraoperative, I mean, even without an intraoperative OCT, you could do a descemetopexy, isn't it? I mean,
chances of entering a wrong plane are there, and sometimes we have to retake the patient to the OT. So those chances are minimized. Though these days, I mean, it's more of like academic tool. We learn a lot by doing AIOS2025. It's not necessary, but there's additional tools.
Okay. So this is the bonus you get when you buy an OCT. Now let's come to, please sit. Now we come to what you get to know from OCT in glaucoma. And we have Dr. Sagrika Patyal. She's a very senior ophthalmologist, retired from the army. And she will be discussing, she's also in Center for Sight, and she'll be discussing about role of OCT in glaucoma.
Thank you so much, sir. And I'll go straight into what is the role of OCT in glaucoma. We all know that glaucoma has come a long way. So from, just think about it, 1991.
Before, 1 second, Sagrika, is Dr. Richard Gale here? Yeah, okay, thank you. I think maybe we'll take you up after this lecture.
So we've come a long way from 1991, where we didn't even see the first 2 OCTs. And now we have come down to swept source OCTs. And we are awaiting a lot more into our armamentarium. It's a non-contact, non-invasive imaging technique. It's very useful for diagnosis, prognosis, progression, and many other things which I'm going to talk about. So I'm going to talk about a serving soldier who was a serving officer, who was 57 years of age. He had no family history of glaucoma, no history of myopia, did not suffer from any eye diseases, was not on any systemic long-term medication, no history of trauma. But when an NCT was done for him, it was found that his right eye pressure was 31 and left eye was 22. This was again repeated by means of applanation tonometry, where we found that at 8:30 in the morning, it was high, 28.3 is high in the right eye, and so again repeated, it was 25. Left eye was just about marginally okay. His Humphrey visual fields were absolutely normal, and he, because it was in 2010, then was taken up for the straightest time domain OCT by Carl Zeiss. It's very easy to see that where my marker is there in the blue, that there is a definite area which is borderline. Now, the axial resolution of this OCT is only up to 10 microns, 10 millimeter. We find that there is significant inferior retinal RNFL thinning in the right eye in comparison to the left eye, depicted by yellow color. Is that significant? Of course it is, because we know that structural loss precedes functional loss. So you might find that the field is absolutely normal, but OCT is giving us some information. Some further information. Have a look at the rim area, right eye and left eye. In the right eye, it is the rim area which is so important, the NRR which we talk about. It is only 0.53 millimeters square, whereas the rim area in the left eye is much more, almost double. Therefore, telling us definitely that this patient's rim area is less in the right eye. Again, confirmatory, we have a look at the optic nerve pictures and we find that there is an inferior notch in the right eye in comparison to the left eye. So what does OCT help us do? It helps the glaucoma specialist for diagnosing. It also lends support to us to start our treatment. We go to a second case. So this was a 42-year-old female who complained just of headache, very vague symptoms, and the patient's NCT was normal, that this person was myope in the right eye, not very great, but yes, high cylinders, and also in the left eye she had hypermetropia. But the specialist concerned found that she had large optic discs, and I have drawn in the next picture, these are my drawings over here, which show that the abnormality of the optic discs. She had absolutely open gonioscopy, open angles, and the pupils were normal. The question was, does this patient really have glaucoma? The CCTs are thin. It is only 452. We all know that in Indian eyes, it varies between 530 to 550 microns. Gonia's open angles, fields are normal, in IOP is normal. Now we go to OCT, and we have a look, and we find that the OCT in the right eye over here, we find that there is no hot color in the inferior part, and so also in the left eye. Now let's have a look at the pictures of the optic discs, and you find that the right eye is looking more or less normal, but there is a huge area of PPA out here. We can find that there are good retinal nerve fibers present out here. In the left eye, it's an absolutely abnormally shaped disc. Whereas the RNFL, when we look at the RNFL, we find RNF is normal. So this is definitely an optic disc tilt torsion in the left eye, large PPA in both the eyes. OCT does not have normative data of such discs. Therefore, how do we now diagnose glaucoma in such cases? Diagnosis of glaucoma depends upon serial AT fields and serial OCT, because now this patient's OCT becomes the baseline for this patient, and we go ahead and keep on doing serial OCTs as and when the patient comes, when we call the patient, and then we check back. Now, we have to remember a very important fact is that check the signal strength of every OCT that you're looking at. This is an RTVO OCT where we know as per the manufacturer, it should be over 40. In this patient, we found that the SSI in the right eye was 55 and in the left eye was 31. And we also found that the RNFL, average RNFL thickness in the right eye was 58. We all know that average RNFL should be approximately 98 to 100 in Indian eyes. And the left eye was 98. We also realize this, that the difference of 9 microns between the average RNFL thickness between the right and the left eye, you should be closely followed. Now, look at how the signal strength affects the OCT. This is one patient for whom the OCT was done, and this is where the signal strength was only 41 in the right eye. And of course, the patient came to me saying that the father said, the patient has glaucoma. Please, ma'am, have a look at it. And when we did it again with a better signal strength, the patient was absolutely normal with normal signal strength. Same thing, another patient where we find that again, the right eye is showing that there is definite RNFL thinning. Again, you do a very good signal strength and you find it's absolutely normal. So this is one thing that every glaucoma specialist should definitely have a look at. We must understand that some OCTs give us a lot more information, like for example, the RTVU. In this, it has a patented FLV, that is focal loss variance. It measures the amount of focal loss over the entire ganglion cell complex. And mind you, the GCC in different machines covers up different areas. That's very, very important. Let's look at another case. July 2018, 61-year-old male. Vision was, the patient had, of course, myopia, left eye more, and we find that in the examination, he had NRR, loss was present definitely inferiorly out here. And you can see another thing, there was a splinter hemorrhage, and the pressures were absolutely normal. Correspondingly, we find that the field had a definite defect in the right eye superiorly, and then look at the OCT, we find there was definite thinning in that corresponding area. We went into 2019, again, same defect, left eye absolutely normal. 2020, now the defect has started enlarging in the right eye. Left eye is absolutely normal. And you see, the OCT is also telling us, hey, look, we've become borderline in the right eye. Left eye is still normal. And then in 2020, absolutely no change in the right eye, no splinter hemorrhages. But in 2021, we find that there is a slight increase in the field effect in the right eye. Left eye is absolutely normal. But lo and behold, what does the OCT tell us? That the right and the left eye RNFLs are definitely disproportionate. I mean, they have also been affected. The pressures were normal, patient was on latanoprost. Then why is it that the patient has got a structural defect also appearing in the left eye? The IOP is controlled. Is the blood pressure under control? So imaging was done. The patient now suffered from hemiplegia. What is to be understood that this patient had infarcts. Astrani in 2024 has said that decreased thickness of the RNFL and GCL has been reported to be correlated with the extent of cerebral small vessel disease on MRI. Along with that, it can also occur in many other diseases like kidney disease, etc. Now, Holter report cardiology was absolutely normal. A 46-year-old lady who was a hypermetrope, look at her axial length, 21.75 in the right eye and 21.83 in the left eye. Unable to do fields, which a lot of our patients are unable to do. So I had a look at, clinically we found that the optic discs were relatively small. Tried to correlate it with the OCT finding of the disc area. We found it was approximately 1.71 millimeters. And we all know that this is definitely a small disc. A small disc should have practically no cup. In this patient, the patient had a cup. And you look at this now this is, oh my God, I'm so sorry. This patient, of course, the field, the OCT which I'm now showing you is not of the OptiView, but this is of the newer OCT which we have just got, and that is of the NIDEC OCT, where we find that the right eye is showing that there is definite thinning. Only 71 microns is the number of the RNFL in comparison to the left eye. And also the GCC, which is present again, I've marked it by red, by the blue arrow, which is telling us that there is definite a diagnosis of glaucoma in the right eye. So what does OCT do? It's an objective method to determine if the patient is progressive, if the patient is unable to do fields. So this is a very good method. A 56-year-old lady, we get lots of them, who are very high myopes. Now, in 2010, she was found to have approximately 16.5 right eye, and in the left eye, 14.5. And her pressures were normal, CCT was normal, gonioscopy had open angles, and she underwent LASIK. And then, of course, her corneal thickness decreased. She was put in latanoprost in 2014. So this patient is a case of high myopia, follow-up from 2010 to 2025. I'm sorry, I have finished time.
Yeah, you another minute or so?
Okay, sir. So look at the axial length, 29.65 and 28.11 millimeters. And look at the various types of OCTs that have come with the patient. 2010, straightest. 2014, RTView. 2016, RTView. But everywhere it is telling us that the right eye is the damaged eye, and then subsequently, left eye also is showing damage. Then in 2019, same thing. But now we come down to the NIDEC. NIDEC gives us, this is a special thing that it gives us the axial length is included and Asian descent. Remember, we cannot have Caucasian data we can't compare oranges and apples. So it's this Asian descent was included, and we find that there was both RNFL as well as macular thinning. And these are her fundus pictures. This was another patient. You'll find that in myopes, there's a lot of truncation which happens in the OCT pictures, so be careful about them. There was another patient who has got unilateral advanced glaucoma, OCT differences. Now look at this. This is the Cirrus OCT. Have a look at the signal strength. Not at all good in both of them, but it is definitely showing us that the hot colors in the left eye have gone. It's a sea of blue. And then again, the patient comes to us with the RTVU. We find that definitely the left eye is the affected eye. And then he goes on to the spectralis. That also tells us that definitely it's the left eye which is the affected eye. So we have to also understand, little children, 6 years old, 7 years old, get referred to us as a case of query glaucoma. Please understand, we can do the OCT and use the patient's own data without using the normative data in order to go ahead when diagnose the case and follow up the case. This is a case of papilledema. One must have a look at the clinical features, medullated nerve fibers, all of which give us a very good idea about whether a patient is actually having glaucoma or some other disease. Nothing can prevent us, or rather, we have to have a look at the clinical findings before we just go along and take an OCT and say that this patient has glaucoma. So don't treat an OCT. A comprehensive ocular examination is an absolute must. Search for causes of retinal thinning. All may be not due to glaucoma. Glaucoma may coexist with various diseases, and other investigations, including CCT, DV, are very important, with emphasis on history and risk factors. Thank you so much. Thank you, sir, for
Thank you,
giving me
Dr.
that extra
Sagarika.
minute. Thank you, sir.
I think one thing should be clear. I mean, while we stress on OCT with retina, but remember, the retina will destroy the macula and the central field. The glaucoma will destroy the peripheral field if you are not careful about that, and if you miss glaucoma in the presence of a retinal disease.
Absolutely.
So I consider it equally important that when I'm evaluating a patient for macula, should also make sure I don't miss the glaucoma. And the OCT for RNFL is an important part of my workup for retinal disease also. I think one message was clear, was that when you're evaluating the OCT, check the signal strength. If the signal strength is not good, you could get a misleading picture. That's one. The second thing is, changes in OCT can give you the basics for screening with a field, which takes much longer.
Yep.
And thirdly, if you have a situation where the OCT on a sequential follow-up is showing changes which are increasing, you may use it even for treatment.
Absolutely, absolutely.
Also. In addition to this, if there are any other questions from the house, please go ahead. Do we have any questions from anyone in the audience?
What about AIOS2025-OCT in glaucoma?
Yeah, we have AIOS2025-OCT, but sir, I would definitely place my bet on gonioscopy, and a proper good gonioscopy done in the correct methods, that having a semi-dark room, etc., before I say that place my bet on an AIOS2025-OCT.
I think for a general ophthalmologist who has an OCT within anterior segment OCT, to rule out angle closure, it may be a great idea, especially if you don't have a glaucoma specialist around you. So yes, I think that makes a difference also. It may not be the best way.
I appreciate your comment. I appreciate your wisdom, and I admire it, but I still stand. You cannot replace gonioscopy with any other tool.
No, I'm not saying you replace it. I'm just saying that you may not be as good with a gonioscopy as a basic screening.
But the unfortunate thing is that too many PIs are done just based on the AIOS2025-OCT, which
so
is
not that you do a PI, but I would not dilate if I have a doubt.
Yeah.
Which even today, even if I have a clinical doubt, I first get a gonioscopy done. Now, if you're alone in your clinic and you have this, at least you can check out whether you should take a chance or not.
I think we should stick to gonioscopy. Already biomicroscopy skills have come down based on the OCT. Indirect ophthalmoscopy skills are coming down. I think better.
Yes, so our skills are becoming less. So that from that point of view, it's better to have.
I think there was a wonderful thing on obituary for the of the clinical findings. So it's very important for us to do.
Thank you, Dr. Sagarika.
Thank you so much.
The next 3 talks are related to retina. And before we come to those, let's come to the management of retinal diseases with anti-VEGF drugs. We have Dr. Richard Gale here. He's giving a keynote address on are all anti-VEGFs the same? And this will also, you will need all this information when you're going to interpret what we tell you about the OCTs in retinal disorders. Please go ahead.
Thank you very much, and it really is my pleasure to be here. I'm just loading up the slides here as we're running through them, if they can be put onto here. And the context of this is that certainly in many areas, anti-VEGF era has halved the amount of blindness within the community, particularly from neovascular AMD. And I'm just loading these up if I can, or if you can load them up for me. So it's half the amount, but the fundamental question is, are all anti-VEGF agents the same, particularly within the current environment? And thank you for bringing up these slides. That's very helpful indeed. So a few disclaimers, and please note my financial disclosures before I start. So we're going to explore the molecular properties of anti-VEGF agents initially. And I think this might be familiar to many people. There are really 5 characteristics that combine well to how well an agent suppresses anti-VEGF. There's potency, the strength, there's the affinity, how well it binds to the molecule. There's the targets, and those targets may be different. There's the dose, and something called ocular clearance, how well it's cleared out of the eye. So we're going to look at those first 3 initially and come to the rest later. So we're going to talk about aflibercept initially, and aflibercept has a very high potency, has a very high binding to a low dissociation constant, and actually binds a whole range of targets, not just VEGF, but galactin-2 and placental growth factors, for example. So it makes it well positioned to block anti-VEGF. So let's just talk about VEGF pathway. The 2 principal pathways are the VEGF-A pathway through VEGF receptor 2. There's placental growth factor, which blocks VEGF receptor 1. And both of those mediate to cause inflammation, neovascularization, and retinal vascular leakage, which are the main reasons why we cause vision loss in these retinovascular diseases. So not all anti-VEGF agents work solely through these pathways or completely through these pathways, and may look at different pathways. But aflibercept binds VEGF-A and in fact traps placental growth factor as well. So stops that cross-talking between those VEGF receptors and hence neovascularization. And there's evidence for all this, that actually placental growth factor is important in diabetic retinopathy leakage and perhaps also in preventing neovascularization as well. So let's just explore the durability of anti-VEGF agents. So why is this important? Well, the durability, the how long it lasts, is mooted to be the biggest or one of the biggest unmet needs that most physicians, ophthalmologists feel is lacking with agents at the moment. Our ability to extend longer intervals to reduce the burden on patients and healthcare systems alike. So let's just talk a little bit about the traditional treat and extend approach, which allows an interval extension up to every 12 weeks or so. And we can see these really good studies here. Principal studies looking at ranibizumab, bevacizumab, and aflibercept, and they all actually have good visual acuity outcomes through year 1, year 2 with a positive gain. But we can see from the middle line there that's actually quite burdensome in terms of the amount of treatments. And in fact, about 20 to 30, perhaps even up to 40% only get out to 12 weekly dosing here. But there are level 1 evidence, which is through indirect comparison. We have to be a little bit cautious with indirect comparison, looking at key studies to try and understand which medication, which treatment regimen are more favorable. And there's a comparable visual gain with ranibizumab compared with aflibercept. But we see that there's typically in year 2, less intravitreal treatments required, and that addresses this unmet need of reduced amount of treatments that we're searching for in our treatments. But actually it's not just real world, it's not just randomized clinical trials, but it's also real world evidence that supports this. So on the left hand side here you can see 2 key trials, the Altair and AIOS, looking at and studying aflibercept 2 milligrams. And on the right hand side, and particularly the far right hand side, real world evidence from Moorfields, where we see that there's still good visual acuity gains through year 4. But indeed, there are still a number of injections required, perhaps over in 3 or 4 in the final 3 or 4 years. So in diabetic macular edema, there is a similar picture here. So good visual acuity gains with aflibercept 2 milligrams. And in these studies, which are particularly from East Asia, we see good visual acuity gains, but again, with a significant amount of retreatments required through year 1 and year 2. So let's get back to really where the new generation of anti-VEGFs are supporting this concept now. So there are through either new molecular targets or in particular molar dose. So aflibercept 8 milligrams is 4 times more than 2 milligrams, so a higher molar dose. But actually surprisingly through study, the formulation seems to clear out of the eye at about a rate of 1/3 less quickly than than the 2 milligrams. So this is sort of additional benefit that many people were surprised about. And what does that mean? It means that when it was studied in good quality randomized controlled trials, and this one is the PULSAR trial studying neovascular AMD, that around about 6 out of 10 individuals were achieving 16-week intervals or more when treated with 8 milligrams of aflibercept. And that figures about 4 out of 10 of greater than 20 weeks, or 20 weeks or greater than 20 weeks, through to studies of 156 weeks into the clinical trials. And very similar study with the PHOTON study, which was an equivalent or similar study studying patients with diabetic macular edema. So about 7 out of 10 and 5 out of 10 respectively, participants treated with 8 milligrams were being assigned to 16 weeks or more, 20 weeks and more respectively at the end of the study. And that's actually quite a shift in what we've seen from the first generation medications. So it therefore brings this concept of sustained disease control. And what do we mean by that? We mean really the triad of lasting visual gains, good, robust fluid control with extended treatment intervals are wrapped around a safety profile. Now what's very relevant, and particularly in this part of the world, is the treatment of polypoidal choroidal vasculopathy. And let's just have a look at monotherapy. So monotherapy with aflibercept 2 milligrams has been studied in PCV in relatively small numbers in the VIEW studies, as we see on the left-hand side, but with good visual acuity gains. And then specifically compared with monotherapy plus rescue therapy with PDT in the PLANET study. And once again, we see good visual acuities. But what was interesting of this study is actually monotherapy worked just as well, and numerically slightly better than the combination with photodynamic therapy. And really, this meant that more than 80% of patients didn't require the photodynamic therapy and led to APVRS releasing the comment that this level 1 evidence supports its efficacy use as the first-line treatment in polypoidal choroidal vasculopathy. And actually that's quite different to the EVEREST-2 study where ranibizumab was compared with ranibizumab initially with PDT versus ranibizumab alone. And in that circumstance, ranibizumab alone required more treatments and didn't have the same visual acuity outcomes. Not quite as good there. So perhaps if ranibizumab is used and we're wanting the best evidence for best outcomes, then it needs to be combined with photodynamic therapy. So it has been studied in different newer generation medications, and we'll just talk about that. So with infliximab, that also targets anti-VEGF, a relatively small amount of patients were confirmed to be studied in Tenaya and Lucerne study, and hence the development of the SALWEEN study, which looked very specifically of a PCV population in Asia. And I think it'd be fair to say that there were an increase, and a good increase, in visual acuity, but what hasn't been studied is whether there was benefit in having photodynamic therapy in addition to this particular medication. And in fact, that's the same situation when we look at brolucizumab. There still is that unanswered question of whether there could be an enhanced benefit or any benefit at all of adding in photodynamic therapy. So real-world patients with polypoidal choroidal vasculopathy do achieve comparable visual acuity gains to those with aflibercept 2 milligrams, as we can see here, around plus 6 to 7 letters out to year 1 and year 2. And in fact, the aflibercept 2 milligram monotherapy achieves control of polypoidal lesions, so closure of the lesions in real-world cases in around about 40 to 50, even up to 75% of cases. And it's the closure which are really quite important. So what about aflibercept 8 milligrams at 4 times higher molar dose with reduced clearance? Good visual acuity gains, numerically slightly better than 2 milligrams than the non-PCV cases. Good sustained retinal fluid control, but we see here that with less injections, 7.7 through year 2, and that gives longer extensions in the long term for our patients. So just quickly in the last few moments, exploring the safety profile of anti-VEGF agents. Of course, the more we challenge the immune system with proteins, the more we might expect inflammation. I think it'd be reasonable to say that from real-world evidence, polatuzumab has a higher intraocular inflammation rate that's been reported in many jurisdictions, and a much lower with faricimab, and numerically slightly lower again with aflibercept 2 milligrams and 8 milligrams, with over 84 million doses launched. Sold since launch. It really gives us confidence that that aflibercept is a safe molecule to use in clinical practice. So 2 milligrams and 8 milligrams have similar low rates of inflammation in the both pulsar and the photon study. So just to summarize, so aflibercept 8 milligrams has a very favorable binding affinity and potency. It's 4 times a higher molar dose, and therefore explains this longer durability profile we're beginning to see. It's also effective in polypoidal choroidal vasculopathy. And I'd like to thank you very much for your attention. Thank you very much.
Thank you, Dr. Gale. Please join us on the dais. Are there any questions for Dr. Gale? Otherwise, maybe we can have a discussion at the end of the lectures.
Was any independent
Yeah.
study conducted for 2 milligram and 8 milligram for inflammation, ocular inflammation? Any independent study between these two doses?
Yeah, there's been no separate study specifically looking at safety profile, but safety profiles are a really important outcome in the landmark clinical trials. So the photon study was a phase 2/3 looking at both efficacy and safety, and a very important outcome in neovascular AMD. And the balance of intraocular inflammation is very similar between the anti-VEGF, between around about 1 to 2%. And that's if you look really hard for it indeed. The inflammation that we're most concerned about is occlusive retinal vasculitis, and there were no cases reports of occlusive retinal vasculitis in either of the groups in both of those 2 studies.
Thank you. Okay, so we'll now have Dr. Purnima Sood, who's going to tell us how to read the normal retinal OCT, various layers, their clinical significance, and after she's done that, then we will talk about the pathological changes of the OCT in various retinal disorders. And finally, we will conclude with the newer things which we can learn from OCT, including OCT angio, which Dr. Naresh Yadav will tell us.
Good afternoon, everyone. I would like to thank Dr. Talwar for this opportunity. So I'll be talking about what do we look for in a normal OCT macula, what are the features we can see, and what do they mean. So I'll be talking about the basic features, and then Dr. Talwar will talk about which disease will have which features. So OCT, as we know, is possible because of varying levels of reflectivity from the different retinal layers. We do a qualitative analysis and we do a quantitative analysis. In the qualitative, we look at the overall anatomy or morphology of all the retinal layers, any change from the normal, any change in reflectivity patterns, hyper or hyperreflectivity. And then we look at the overall quantitative, that is the thickness and volume of the retinal layers. There are various retinal scans, line scan, radial, raster. But a line scan will give you a lesser information because it will only be in that particular, that meridian that you're getting. So preferable are raster or radial. In raster, you get multiple parallel serial scans in horizontal, and the radial you have focused on the center at the fovea with 360-degree around it. So it's very important that you get the lesion in relation to the fovea, the relation how far it is. So that's very informative. So these are just some. So many lesions you will pick up when you see in raster or radial, which you might miss on the line scan. This is the normal OCT macula where there's a central foveal depression. And we are able to see all the layers very clearly because the anterior RNFL layer and the posterior RP layer are very highly reflective. And the other layers in between are of medium or low reflectivity. So each and every layer, you can see here, each and every layer is very easily seen. Sometimes you will see colored pictures, though we are seeing less and less nowadays. More of us are seeing black and white, which give better resolution. But these colors, you should know, are false colors. And so what do they represent? The layers with high reflectivity will appear in the orange or the red section, like the nerve fiber layer, the RP layer, while the layers with medium reflectivity will be in greenish color, like the plexiform layers or the AIOS layer. And the layers with the least reflectivity, they will appear either bluish, blackish, so like the nuclear layers at the choroid, and of course vitreous, which is totally black. So whenever we are evaluating, first of all, look for the quality of the scan, then the position of the scan, and then assess the layers. In the quality, you should be able to see both the inner and outer retinal band. There should not be much of noise or haziness in the image, and then no shadowing effects. So now look here in the first picture, you cannot see inner and outer band in a few areas. Now this is not because of some problem, but you see this thick membrane here, which is causing a shadowing effect, so you're not able to see these. And in the second, you see there's over a lot of haziness, and this can be due to any media opacity, like this was the cataract related in this case. Sometimes you will see some features, but which are not really due to any pathology. So you have to see what they are. Like here, you can see there's a gap here. Here, there's some, wave-like structure. So this is because of some artifacts. So whenever you are in any doubt, always look at the clinical picture. If you feel it is not correlating, then repeat the scan again. So this can be due to eye movements or any blink or any other problem. So coming to the position, always look for the foveal depression. That is very important. Otherwise, you'll always get a false information. If the patient is not able to focus with that eye due to low vision, then you can always try to fixate the other eye with external fixation, or you can manually shift the focus to where you assume the macula to be. Now here you see you're getting an impression of edema, but this is below the macula, so you are getting a false impression. Then coming to the actual assessment. So it's better if you see it in different regions or zones. So we have a pre-retinal area, an epiretinal, intraretinal, and the sub-RP or the subretinal. Now these are the terms that you will usually use to describe the changes in the various layers, any interruption, elevation, thinning, thickening. So this is how you're going to describe them. So coming to the first, the pre-retinal region, this is vitreous, which is not reflective at all, so it's black. But you may sometimes see some kind of reflectivity. Now here you see this membrane, which can be a PVD, or a thick membrane, which can be an epiretinal membrane. Sometimes you may see this kind of a diffuse hyperreflectivity, which can be due to a vitreous hemorrhage or any exudate in the vitreous. Second is the epiretinal area. So this is actually interface between vitreous and retina, and normally this is very smooth and regular. So the kind of changes that you can see here, so you can just see that this is this membrane. So this is an epiretinal membrane causing irregularity of the retinal surface. And sometimes this may become so, cause so much of traction that it will distort the whole retinal surface and make it irregular. Some other features that you can see in this epiretinal area, attachment of a membrane, which is called VMA or vitreomacular adhesion. And if this adhesion starts pulling up the retina, then this is VMT or vitreomacular traction. Now here you see there's so much of traction that it has pulled up the whole retina, causing a plateau kind of a TRD. Sometimes abnormal structures present near the fovea may lead to alteration. Now this particular patient actually had a NVE very close to the fovea. So this was showing in the OCT macula like this. Next comes the intraretinal layer. So what are the changes that we see here? Mostly the hypo and hyperreflectivity patterns, then overall thickness of the layers, and then the integrity of the retinal layers. Now coming to hyporeflectivity, whenever you see hyperreflectivity, you will see dark black areas. Usually they will indicate fluid, that is edema. Now you look at the pattern of these. Now here you see this is a diffuse black hyperreflectivity, so this is a diffuse retinal edema. And you also note, see it is respecting the vertical meridian, it's only on one side. So Dr. Talwar will tell you that which are lesions where you can see this kind of edema. And otherwise you may cystic spaces. There may be small cystic spaces or there may be large cystic spaces. So this is a cystic edema. But not all hyperreflective spaces are fluid. Sometimes you may see these kind of hyperreflective spaces, but they are not due to fluid. They are due to atrophy of the retinal cells or degeneration. So how do you differentiate? It has to be a clinical examination. So good thorough 90-day examination, which will help you differentiate any clinical macular edema. Then we look at hyperreflectivity. So here you see these hyperreflective lesions. These are in the outer retinal layer, usually representing a CNVM. So we can look for them, and sometimes these hyperreflective lesions may be very intensely reflective, like these, like in hard exudates. So they will show a shadowing kind of effect. Next, we comment on the thickness and thinning. So any kind of edema will lead to increased thickness of the retinal layers. Any atrophy will lead to thinning of the retinal layers. And finally, we look at the integrity. Are all the layers intact or not? So here you can see in the center, there's a complete loss of retinal layers. So this is a full thickness macular hole. And sometimes you may have a partial loss, not complete. Some layers may still be present. So this is a lamellar macular hole. Finally, coming to the subretinal and the sub-RP region. Now here, hyperreflectivity again is very important, but in correlation to the RP layer. Is the fluid above the RP layer or below? So if it is above the RP layer, then it is subretinal fluid. And if it is below the RP layer, then it is a PED or a pigment epithelial detachment. So it's very important to differentiate because the management of both is very different. Coming to the RP layer, this is a very important layer because many times the status of this is going to tell you what the diagnosis is. So these are again, I'm emphasizing the terms that you use for defining the changes in this. These are some of the changes that you can see in the RP layer: undulation, elevation, thickening, thinning, so disruption. So this is, you have to look very carefully for these changes. So I'll just give an example. So a case where you can see cystic edema, you can see subretinal fluid. Another case, similarly, you can see cystic edema, but are these both the same? Look at the RP layer here and RP layer here. Now the RP in the second picture you can see is undulated. So which tells that no, these are not the same, they are very different. Another example, you can see subretinal fluid here. Another picture, similar subretinal fluid, but look at the status of RP layer. Here it is straight, but here there is a PED along with undulation. So again telling that these are entirely different pathologies. When we're talking of this area, another term that you should all know is the ellipsoid zone or the AIOS junction. This is very important. So this is where the photoreceptor inner segment, outer segment junction is there. The integrity of this is very important for prognosticating your the visual function. So wherever you can clearly see this, you know the patient is going to recover good vision even if there is edema. But where we have a loss of this AIOS junction, there we know that even if the edema resolves, patient is not going to recover good vision. So it is good to help and inform the patient. One another term, this is drill, that is disorganization of inner retinal layers. So now this time it's the inner retinal layers. Within 1 millimeters of the fovea, if you're not able to distinguish the normal retinal layers, that is the plexiform layer, the nuclear layer, so this is known as drill. And this may occur due to long-standing edema, NDME or BRVO or any other edema edematous condition. So this again leads to poor visual outcome. So finally, coming to quantitative analysis, this is overall mapping the thickness and the volume of the layer. This is very important because serial 3D scans tell us how it's the responding to treatment, whether we need to change our treatment pattern. So monitoring that is important in this. So finally, whenever you're looking at OCT, you should know which disease may show which features. You should go systematically through all the points and always correlate clinically with the clinical pictures and the disease symptoms. Thank you.
Excuse me. We'll take these 2 lectures, in fact the 3 lectures together we can take. Thank you. Ladies and gentlemen, you've already now been exposed to what are the kind of abnormalities you see in the retina on an OCT. Now, let's now discuss their significance. This is my disclaimer. Now, the fact is that OCT is the bedrock on which the management of retinal disorders is anchored, both in terms of their diagnosis and in terms of their follow-up. The abnormalities that we will see, they can be used for diagnosis, for treatment, for follow-up, and for prognostication. So let's start with some of the basic abnormalities. First, we discuss OCT in AMD. This could be dry or exudative, and the dry form could be drusen or geographic atrophy, and then you have the exudative type. So what you see over here, you see the undulation of the RPE. This is basically due to drusen. This is not a wet AMD, nothing needs to be done. But within the wet AMD, you have a situation where you now see that the ISOS junction has got disrupted. there is a subsidence of the outer plexiform layer and the inner nuclear layer, as well as the outer nuclear layer here. And this is a nascent geographic atrophy. So the geographic atrophy is now setting in. It's still dry, but it is likely to cause vision loss in this situation if the fovea is involved. Then you come to the exudative forms of AMD. This is type 1, where the fluid is basically under the RPE. You have an RPED, and then and in addition to that, you also have subretinal fluid, and you could have intraretinal fluid also. Then you have type 2 CNVMs, where the main lesion is above the RPE. It's amorphous looking, especially you see this part is quite active, and this needs to be treated, but the prognosis is different in the two types of lesions. And finally, you have type 3, what we call RAP lesions, retinal angiomatous proliferation, and there the lesion, the neovascular tissue starts within the retina and then goes down, creates an RPD over here, as you can see, or it may be only in the retina, as you see in this arrow. Can you see this? So this is the early form, that's the later form. Now, OCT can not only help you to diagnose. What you can see here is a type 2 CNVM, but this is a case where post PDT you can see how the lesion disappeared and only hypertrophy of the retinal pigment epithelium was left, which you can see as this darker red line than usual. You can also characterize this pathoanatomy, and you can monitor the effects of your treatment. For example, with the anti-VEGFs that we are talking about, you see SRF with an RPED. With treatment that has gone away, and then the RPED has become much less, but when a recurrence occurred, intraretinal fluid started appearing again. First evidence, even before the vision may get affected. This is another patient where there was a retinal pigment epithelium detachment, very large but sparing the fovea, was followed up till fluid appeared and then was treated, and then this lesion ripped. The RP, you can see there's a discontinuity here. It has ripped. There is fluid, but it still needs to be treated. This is a form of degenerative change of AMD, where you have thinning of the fovea, and you see this cartwheel-like appearance. This is actually not fluid. This is what we call outer retinal tubulation, and this is a sign of severe degenerative change. The other condition where we see OCT changes very commonly are, of course, central serous chorioretinopathy. You can see here there's a neurosensory detachment, and sometimes there may be a small RPE detachment, which will be where it will correspond to the site of a leak on fluorescein angiography. In a chronic CSCR, the added changes that you see is that in addition to the neurosensory detachment, there is this brush border kind of sign, where there's an accumulation of waste products in the photoreceptor outer segments, which you see here. You see it becoming thickened. This is a sign that this is now a chronic form of this disease. And here, the other thing that you see, if you do what is called an enhanced depth imaging, you can see that the choroidal thickness has increased. So the presence of choroidal thickness virtually confirms with you that when you have this with a neurosensory detachment, that you're dealing with a CSR and not with an AMD lesion. This looks deceptively like a CSR, but if you see, you'll see this layer is going up like a dome. On the other side, and this is in the horizontal meridian, in the vertical meridian, it is very important to have this along with you. And here you see that's not there. So this is a dome-shaped maculopathy. Unless you do it in both the meridians, you will miss out the diagnosis. And this, unfortunately, we do not have any treatment, but is usually not a progressive disease. Dr. Gale talked to you about polypoidal choroidal vasculopathy. The importance is, even clinically, you can recognize that it has more of exudation, sometimes a lot of hemorrhage. But when you do the OCT, you'll see this irregular, shallow RPD with a double layer sign. There's another layer under this, which is actually the branching vascular network. So in addition to that, you also see these very peaked PEDs. This looks like a tomahawk sign. So it's actually called a tomographic notch sign. It's a sharply elevated PED fluid. This
double layer sign, these are all signs that now you're talking about a PCV. You can actually diagnose based on OCT alone. So what all will you see? A sharp peaked PED, like you see over here, sharp peaked PED. Double layer sign, I've already shown you within this. Thick choroid with dilated Haller vessels and a fluid compartment, which you see over here. And then you can sometimes actually see a multilobular PD, like McDonald's, like you see over here. And then you can see also a sub-RP ring-like structure. Look carefully at this. This is where the polyp is. It has a small area which is hypofluorescent, hyporeflective, and around that is a hyperreflective area. But be careful not to be confused by another lesion called adult Whittley-form degeneration, which can give you the same kind of picture of a type 2 CNVM. On fluorescein angiography also you can get fooled because it shows hyperfluorescence, but it doesn't show a blurred hyperfluorescence, shows well-defined margin of hyperfluorescence. So that also gives you a clue. But the best diagnosis comes from the autofluorescence, where you see this area where you had this lesion was hyperfluorescent. So the hyperfluorescent on autofluorescence with this kind of lesion and a hyperfluorescence on angiography which does not increase over time tells you you're dealing with adult Whittley-form degeneration that does not need treatment. The other important condition is a juxtafoveal telangiectasia, often seen in older women around 50 and more. And here you see what are degenerative cysts. It can also have areas of outer nuclear atrophy like I showed you. And on fluorescein angiography, it presents like a late leakage from an unknown source. But this is the difference. You look at the area of the RPE, it's absolutely okay. There is no lesion there. However, these lesions can sometimes develop CNVMs. So when that happens, differences will come and you have to pick that up. Now there's another potpourri of disorders. The ERM, which you can see over here, separated from the retina, causes a blunting of the foveal contour, may require treatment by surgery. Macular hole, is it going to do well? If you look at this and if you see the ratio of these two side walls to the base, and if that is more than 0.9, there's a very, very high chance that the hole will close. If it is less than 0.5, the closure rate goes down significantly. So you can actually predict what is the closure rate based on your OCT. The important thing for cataract surgeons, you have a patient, he was improving and suddenly now deteriorated 2 weeks, 3 weeks after a cataract surgery. Look at the OCT, you find CME. All you need to do is start the patient on NSAIDs and steroids for some time, and the patient will do wah-wah for you all the time. You're a miraculous doctor. The other important condition you need to understand is arterial and venous ischemia. Arterial ischemia is in CRAO, you have inner layer ischemia, and then you can have venous blocks also causing either exudative or ischemic changes. So let's look at this. This is a central retinal artery occlusion, and this patient, you see when the acute phase occurs, the inner layers are completely opacified, and you can easily confirm your diagnosis. With time, this becomes less and finally goes away, but it will lead to thinning of the retina in that quadrant. On the other hand, this is a central venous, central retinal vein occlusion, venous stasis retinopathy, and this will present with edema, and this edema will be in the central macular area. If you do a radial scan, it's there all over. Now the other important thing that you have is a BRVO. In a BRVO, on the other hand, if you do a radial scan, you'll find edema in one half, not in the other half. You can actually make a diagnosis based on OCT alone that you're dealing with a BRVO. So you have these cystic spaces, you have subretinal fluid all in one side in BRVO, entire retina in the macula, in CRVO. In diabetic macular edema, it can help you with diagnosis, treatment, follow-up, and prognostication. The lesions which we have are drilled, subretinal fluid, intraretinal cystic changes and all. Let's see. Now, cystic spaces can be small, large, or very large. Large cysts are associated with poor visual prognosis because of effect on the photoreceptors. So this is the important thing, but all cysts respond to treatment. Large cysts may respond a little more slowly. Hyperreflective signals within a cyst are associated with severe disruption of the blood retinal barrier. Now you see here, large cysts treated with one intravitreal injection, another one, did not become okay, and then was given Ozurdex and finally responded. Neurosensory detachment is another sign of diabetic macular edema, present in up to 15 to 30% of cases, more associated with nephropathy, hypertension, and once they become okay, it becomes better. These patients show a better visual prognosis. It's basically because they don't damage the retina as much as intraretinal cysts do. So you can use the OCT as you see here for following how the patient is doing. He's improving, improving further. The other important thing is drill. Drill is a situation where you have a disruption of these layers. You see the ganglion cell layer, inner plexiform layer, inner nuclear layer, they're all now looking as one mass. This means that this patient has a poorer prognosis if this is in the central 1000 micron of the macula. If more than 50% of this gets involved, the visual prognosis is worse, and this is a good prognostic marker. But see over here, this was a patient with no drill. He developed edema, and it looks as if he's developed drill. Edema went off, the drill reversed. What did it mean? Basically what is happening is edema caused, those cysts caused a crowding of the retinal structures, made it look as if it was amorphous. The crowding went away and it came back. So you talk about drill only when there are no cystic spaces. If there are cystic spaces, it's not drill. Then you have to first wait for that to resolve. So we know that patients with subretinal fluid do better, patients with absence of HRF, hyperreflective foci, do better, and most importantly, patients with an integrity of the ISOS junction do better. Now, if the patient has a lot of hyperreflective spots, the basic thing is, if there are very large in number, the chances are these patients will have early recurrence after treatment. It's not that they don't respond to one treatment or the other. Both subretinal fluid and hyperreflective spots will respond to both anti-VEGF agents and steroids. I've shown you here, this patient had an intact ISOS junction, this one didn't. This one had a good prognosis, this one did not. Now just completing, this is the last part just to show you, this is the map of the macula. Shows there is leak over here, even though, so you know this, if you have to laser, this is the area that needs laser. If it was the entire central area, it will not respond to treatment. These bridging retinal processes are a good prognostic sign. These are bridging processes. It means still communication is there between the inner and the outer layer. So ladies and gentlemen, you can see there are lots of things to be discussed. You can ask whatever questions you want, but it's quite obvious to you that this is a workhorse for us for managing, diagnosing retinal disorders. It's non-invasive, it's sensitive, provides a detailed insight into the pathoanatomic changes, and has revolutionized the management of retinal diseases. Thank you very much. And I'll now invite Dr. Naresh Yadav, who's a senior consultant at Narayan Netralaya in Bengaluru, to talk about the latest toy that we have for retina, and that is OCT angio, but it's no longer a toy, it's a cannon, and it's a cannon which can give you lots and lots of information. Let's have it now.
Very good evening to one and all. I will be speaking on OCT angiography. What all can it show us? So we all know that FFA and ICG is the gold standard for imaging the retinal and choroidal vasculature, but it's an invasive procedure. It needs a dye to be injected. It rarely can have serious side effects, and the vasculature is seen as a single layer. And on opposite side we have OCTA, which uses motion as a contrast to detect blood flow. It's a dye-less, it is quick, has no side effects, it's repeatable. At each and every visit you can do OCTA, you cannot really do FFA. And it segments the vasculature into the various layers. And these are the various machines that are available. So basically the principle is quite simple. So you do repeated scans are done at one place. So if the tissue is stationary, all the scans are going to look the same. But if the tissue has blood vessels, and in the blood vessel the RBCs are moving, so when the scans, repeated scans are done, it will change because of the movement of the blood vessels. So that is known as, the reflectance will be different. That is known as decorrelation signal. So that is the basic principle. And this, whatever we get resolution images, those are split into low resolution images, and then a average decorrelation is done. This is done by a algorithm that is known as split spectrum amplitude decorrelation algorithm. So this is how it looks. You can see there's a SCP, superficial capillary plexus, deep capillary plexus. Outer retina usually does not have any blood vessels, and this is the choroid capillary. So this is how the octa will give the segmented vasculature. So this is the printout that you get, and you can see the OCT also is there besides it. So you can move the segmentation. You are sure what image you are assessing. So this is one article that we published in 2016. So you should remember that before the patient develops any DR changes on fundoscopy, the octa will pick up changes. So the normal eyes had lower FAZ area, higher vessel density, lower spacing between the large and small vessels. But if you look at the diabetic patients, as the diabetes retinopathy increases or the grade increases, you can see the vessel density is coming down, the vessel gaps are increasing, FAZ also is increasing. So it's a good way to sort of study the diabetic retinopathy, how it progresses. So the other useful indication could be, here you can see there's a retinal hemorrhage. You are not sure whether there is a new vessel here, but if you get a octa, so you can see the vasculature is very nicely seen. You should concentrate in this area where there is a junction of the ischemia and the normal retina. And then if you do laser, so you can, if you do laser, you can very well see the morphology. If you do FFA, it will just leak. But here you can see how nicely the vasculature has changed, the morphology has changed. It is not very exuberant. The anastomosis, looping has come down, and a few vessels are seen, that's all. So it's very good to study the morphology. And it has very good prognostic value in DME cases. So basically, if there are more microaneurysms in the DCP, that will, patients are going to respond poorly. If there is more edema, they are more likely to have aneurysms in the deep capillary plexus. Similarly, the larger the FAZ, they also may not respond very well. And similarly, in DCP, if you see this area of non-flow, so it usually corresponds to the breaks in the outer plexiform layer. So there is a correlation. And the other useful thing is in the AMD. It is very useful. Studies have shown that it picks up the CNVM very well. So this is one of example. You can see a patient, 68-year-old male, complaint of decreased vision since 1 month. You can see there's a NSD here, pockets of IRF, and this is the membrane that is seen. So the octa, you can see how nicely you can pick up the membrane. And this is post-treatment. So you can see the vasculature has come down, the arborization of the vessel is less. So it shows that it is not really leaking. So you can see the change that has happened. And the OCT also, corresponding OCT also shows the same. This is another patient, CNVM. You can see how nicely it is picked up. And this is after 3 injections. So various patterns have been described. Octa in AMD, it can be C-fan type, it can be Medusa type. Here you don't see a distinct membrane, and this is the dead tree pattern. So the other useful thing is pachychoroid neovasculopathy. So Dr. Talwar was talking about chronic CSCR. So basically patients with chronic CSCR can develop CSCR neovasculopathy, that is known as pachychoroid neovasculopathy. So whenever you see a patient with CSCR with a flat irregular PD, you should suspect that you are dealing with neovasculopathy. So studies have shown that in this article, most of the eyes with FIPED had PNV, and similarly, you should not forget that such eyes from neovasculopathy can convert into PCV. It's a spectrum, pachychoroid spectrum. So here is the case. So you can see there's a flat irregular PED. Usually Brooks and RP are seen as one layer, but if there is something growing in between them, it's a separation that is known as flat irregular pigment epithelial detachment that you can see here. So this was a 39-year-old male, recurrent CSCR, and Octa was done. And you can see the vasculature, and such patients have to be treated with anti-VEGFs. And this is after 1 injection, this is after 2 injections, and you can see the change in the tangled vasculature that you have seen. And the other thing is that this is the same, you are seeing a FIPED here, and you don't forget the morphology of the choroidal vessels. Here you can see there's a dilated vessel that is known as Haller vessels. So, and this usually Haller vessels changes in the PED will overlay this. So that also is important. And then you can see the membrane that is so nicely seen. The membranes are mature and they are in one layer. The retinal anatomy is not much distorted. So the Octa picks up this CNVM in a very nice way. If you see the FFA, it does not really pick up. You just see a sort of leakage of indeterminate source, but Octa is very good to pick PNVs. And similarly in PCV also. So this is PNVs can convert into PCV, and Octa is quite useful in PCV also. It is very good to pick up the branching vascular network, but polyp sometimes you may not pick it up. So that could be because of the poor flow. It could be located away from the fovea. There could be error in segmentation, and BVN and polyps could lie in different levels also. It could be a little raised. So if it is not segmented properly, you can miss that. And the polyps also can be seen as hyperflow, hypoflow round structures. So here you can see clinically also you can suspect there is a subretinal lesion here, and this is the corresponding OCT, flat irregular PED, SRF is there, and this is the ICG. You see the polyps here, and Octa also shows the polyps. This is that was the ANFAS OCT, and this is the Octa. So you can see how nicely the branching vascular network is seen, but the polyps are not really that well picked up. So this is another case. This is the ICG. You can see the BVN here, polyps, and BVN is very well picked by the Octa, and this dark could be the polyps. It's a sort of hypoflow. And on Octa it has been described as 3 types of BVN. The major vascular trunk type, it's a BVN that looks like a nephrons, and this is a tangled caliber of vessels. So basically this one has the best prognosis, and these don't really do well. So it tells about the management and the prognostication also. This is another case, one of our cases. You can see the subretinal nodule, how nicely the polyps are seen. And in Octa you can see this is hypoflux flow structure, this is a hyperflow. And here also BVN you can see in another case. And the other useful information that you can use Octa is for myopic CNVM. Any patient with myopia who comes with a sudden decrease in vision, you should not take it lightly. Sometimes CNVM can be missed by just doing a fundus photograph or OCT. So here you see the OCT does not really show any too much structural changes. The CNVMs in myopia don't leak too much. You don't really get very profuse structural changes. So if you just based on OCT, you would have said everything is fine, please go. But if you see the FFA, you can see there's a leakage. But every time you cannot do FFA. So Octa is very good. This myopic CNVMs of type 2, they are above the RP. So it is very well picked up by the Octa. This is another case. This is subretinal hemorrhage. So subretinal hemorrhage also can be because of Lecker crack, which does not really need any treatment. It can resolve on its own. But FFA shows that there is a CNVM, and this is the OCT. You can see the CNVM, there's a blurred margin, and Octa shows the CNVM in a very nice way. Similarly, this is pre-injection, this is post-injection. You can see the change in morphology, and this is the recurrence at 3 months. So myopia is very useful. Myopic CNVM, Octa is very useful. And the other thing is the Mactal. So basically in Mactal, because of the FFA leakage, you don't really get to know what is happening. But the morphology and how the disease progresses, it is well explained by Octa. So we had a publication long time back. So the changes usually start in DCP. There is a dilatation, rarefaction, abnormal communications, and there's temporal enlargement of the FAZ. So Octa can be used to stage the CNVM also. You can do a structural vascular function correlation. So it's very useful in Mactal also. This is a case, you can see mactal, there is an ileum drape sign here, but there is both eyes, there is a PD. So mactal can sometimes get complicated by CNVM formation. So FFA can get some idea, but because of the leakage, you don't really appreciate much. But Octa definitely shows there is a neovascularization here, and this patient will need anti-VEGF. This is another interesting case. Patient had a CRAO. So you can see it was a cilioretinal sparing CRAO. Octa showed, and then this is the after paracentesis immediately. So you cannot really keep doing FFA, but Octa can be repeated, and this shows. And this is hypertensive choroidopathy. The choriocapillaries are not autoregulated, thus making them susceptible to severe rise in BP, and it causes hypertensive choroidopathy. So you can see this flow wide areas. This is the left eye, right eye, and this sort of flow wide area damage to the choriocapillaries can damage the RP. So it can be because of the ischemia, and you can get subretinal accumulation. So it is very nice way to study the extent and the impact of malignant hypertension on the body's microcirculation. Because the patients have high BP, you cannot really do FFA in such cases. So to conclude, Octa provides in vivo visualization of retinal blood vessels in a depth resolved fashion. Dye-related complications are avoided. The indications for Octa are gradually increasing, but small area is imaged. But now we have a little better imaging facilities and machines that can give up to 12 by 12 millimeters. But there's definitely a learning curve, and cost and availability as an issue. Thanks for a patient hearing.
Thank you, Dr. Yadav, for a very well-defined lecture, which has made it very clear as to what are the new things which we can see. You know, till 2 decades back, हम आँख को सिर्फ देखते थे, ऑप्थेल्मोस्कोपी करते थे, ठीक है कुछ स्वेलिंग है, कुछ वाइट है, कुछ पॉइंट है, कुछ डॉट है. Today, we are not replacing your clinical acumen with a machine. We are increasing the ability of your eye to see the ultrastructure of the eye. अभी तक हम क्या देखते थे? Gross structure. अब हम देख रहे हैं ultrastructure. Pathology ka ultrastructure. What is happening exactly in which lesion, which disease, and when we treat it, what happens? So we know much more accurately how to treat. It's like now using guided missiles instead of using one big 2,000-pound bomb and saying everything's gone. So, ladies and gentlemen, you have heard a lot today. Are there any questions from you? Anyone has any questions? Please come forward.
I would like to have one question for Dr. Naresh. So sometimes if there is a large PED in the center, so it's very difficult to visualize the BVN under it. So how do you, is there a way to do anything, seek better?
I think it is correct still that Octa cannot really go through the serosanguinous PEDs. So sometimes if it is serious, you could still get. But I think it's difficult. The only thing is that sometimes at the edges you could appreciate something. Or if you sit at the machine and try to segment, then you may get. But very large PDs, still I don't think you can get good images.
Yes, because
same thing with the posterior staphloma also. If it's a very high myopia, then in a setting of posterior staphloma, it becomes really difficult. But low myopes and all, it's very good to pick up myopic CNVMs.
There's one question from somebody who is on the net. Dr. Sagrika will answer that.
Thank you for the question. And I would like to say that first of all, when we are looking at the Tisnit graph, that's a very important part of the OCT, which we definitely would like to see. So the Tisnit graph shows us, first of all, that there is a superior hump. After that, it comes down. And then again, there is an inferior hump showing where the retinal nerve fiber layer thickness is present superiorly as well as inferiorly. Generally, it is the inferior hump which is bigger. Now, you may also have certain oscillation or fluctuations on this hump, on the rising or the lowering part of the hump because of blood vessels which are present over there, which also the OCT picks up. Now, if we all realize that this is a statistical analysis, therefore, depending upon the normative data in that particular machine, which is generally color coded, normals being in green, yellow being borderline, and red being abnormal. Therefore, if your profile of the right eye, it falls in the green, we know that it is definitely normal. Very important to see is whether that profile, that particular profile is going down and entering into the yellow or the red area, which shows us that in that particular area, the retinal nerve fiber layer has become very badly thinned out. Now, similarly, it is seen in the left eye. What is very good is that now the two profiles are always matched to see whether there's any symmetry or not. We know that in glaucoma, there should be, if it is there other, let me put it this way, that if there is asymmetry between the profiles, we know that we're looking at something highly suspicious. So, we always look at this particular profile asymmetry, and if asymmetry is there, I would definitely like to investigate the patient for glaucoma. The last point which they have mentioned is about hypermetropia. No, there is no great difference between the profile should fall within the normative data as well as the as per that OCT particular OCT machine. But there, as of now, that there is no normative data, like there is no normative data for myopes, no normative data for hypermetropes as such. What is very nice is that NIDEC has got a very robust information regarding the RNFL profile. So, Gulstad 24.38 millimeters is the amount of the axial length which is taken by default in that machine. But suppose, for example, your patient has, let's say, 21 millimeters, so you do the Gulstad and then you put in the 21 millimeters in that patient and you see what is the difference. So if you find that the profile definitely is looking lesser, then I would like to follow up that patient and investigate the patient for glaucoma. I hope that answers the question.
Thank you, Dr. Sagrika. Now, before, yeah, go ahead.
Is there any significance of age when we register for doing an OCT?
Yes, sir. I have already answered that. I couldn't do it a little more in detail. That normally all the machines have it between 18 to 20, the lower age group, up to 84 to 89, the senior age group. So suppose you have got patients who are, let's say, for example, I gave the example of a 7-year-old, then in that case, don't try, because what happens is invariably our eyes fall to the color. Now, we don't go for the color, you go for the number. If suppose, for example, the superior part of the retinal nerve fiber layer is showing 90, 100, 110, we know it's perfectly fine. If it goes beyond that, please have a thorough look once again at the optic nerve head to see is there any other lesion which you have missed out. So that is how you do it. So don't try to do it with the normative data. In that case, you follow up the patient as his own OCT being the baseline.
Thank you. Thank you, Dr. Sagrika. Now, before we conclude, there are only 2 points I'd like to make to you. You don't treat the OCT, you treat the patient. So if you have a patient who's got, say, diabetic macular edema with few cystic changes, you're not going to start treatment if the patient is 6/6 vision and has no complaints. Similarly, for OCT angio, there are situations when you start the treatment, you may use the OCT angio and use it for follow-up. But to conclude the treatment, it is not based on OCT angio, because as he showed also, some vessels will remain. It can be used to pick up an early recurrence, but it cannot be used to stop treatment. This is the other important thing. Also, lastly, nowadays we can sometimes pick up neovascularization, but no exudation is there and the patient is asymptomatic. This again is an indication for close follow-up, but not an indication for treatment. If such a patient develops exudative changes or becomes symptomatic, he may need treatment. So these are some of the basic points to keep in mind. Treat the patient, use the OCT judiciously, and you will be able to deliver better services to your patients than ever before. Thank you very much, ladies and gentlemen, for being over here today.